Okay, so good afternoon to all of you from New Delhi, India. And this is Dr. Praveen Chandra from Medanta, the Medicity Hospital. And along with me is Dr. Abhinav Chabra and also Dr. Ankur, who are going to be working on this case today. So Dr. Abhinav is going to introduce the history of this patient now.
Yeah, hi everyone. So our patient is a 46-year-old gentleman presented with chief complaint of dyspnea on exertion from last few days. Although he has a past history of angioplasty done to the RCA, which was a primary angioplasty, as he had inferior wall MI at that time in March 2023. So now he is planned for the angiogram, and angiogram revealed circ having proximal almost 80 to 90 and distal 90% lesion. LED is also having significant disease in the proximal part, which is around 70 to 80%. And there is a large diagonal which is also crossing away from that point, having osteal disease of almost 60 to 70%. RCA.
And the right artery. So, okay. Okay. Next. So you can see these images in different views that the circ is a very diffuse artery. And the LED was looking like borderline in some views, and in some views going up to maximum 60-70%. And the diagonal is tight, which is arising from that lesion. And the right artery, which was stented 3 months back,
Yes.
4 months back,
It
is
has a
okay. So
patent
this is
status.
fine. This was done as a primary angioplasty to the right coronary artery in some other hospital. And then patient was a little okay after that, but then he started developing symptoms. So then he came to us for further intervention. So we did his check angio, which you have seen already, and the stent is okay. Now, if you look at the left, so go show today's picture. Okay, go back. Today's picture first. Yeah, so here you see that the ramus is a big artery, which is okay. LAD proximally, osteally is okay. And in the middle, there appears to be a borderline lesion, but the circ was, go back, and the circ was diffuse long disease, proximally tight lesion, and there was a distal tight lesion as well. So the plan is to treat these two arteries and get as best as we can outcomes. And there are two issues. The issue number one, that this LED doesn't need to be treated. So we are doing, we did wire this vessel, and we will do an imaging first to see if we find that there is still borderline, then we will do a FFR. So here you can see that the diagonal is very tight, looks like a 2.25 at least a vessel. And also there is a big diagonal beyond this. So we are not too much worried, because sometimes the diagonals are only one diagonal, which is very big. So we will, we've just put the wire. Next, please. Next, yeah. So you can see that we have put two wires. One is in the LED and the second is in the diagonal. And we are trying to do a IVUS. I'll show you the IVUS images. The IVUS images show that distally the vessel is like about 3 millimeters, and then there is a fibrocalcific lesion, very tight lesion, which was not so apparent, and there's ring of calcium also, which is a little not superficial only, not too deep. So which means that we have to make a plan, and then proximally the plaque extends, and up at the ostium also there is some plaque. So we can measure the osteal disease, measure it. How much is the MSA of this? Yeah, so here we can see that the area is about the vessel. It is the lumen. Show the lumen properly. Lumen, yeah. No, this is not the correct lumen. Yeah, okay. Okay, so this is to be corrected. So its area is still 5.5. So we don't really necessarily need to treat it. Angiographically also this ostium was looking okay. Although we saw some plaques, but it is okay. Don't need to treat the ostium. So if you look at this image, we have to treat this as a bifurcation now. And this, since this diagonal is not too big, so our plan is to do a cutting ballooning first of the diagonal and the LED, and then we will do a cutting balloon, because it is a fibrocalcific lesion, and not do a shock wave. If required, we will do a shock wave. Otherwise, we can avoid it, because the calcium is very thin calcium, and generally it responds quite well to a cutting balloon like Wolverine or something like that. Okay, so here we have the balloon coming to the diagonal first. Yeah. So you can see
And why?
that we are able to cross it because this is a balloon which has been, yeah, it's okay. So check, please. Check. Okay, fine. So this is in the diagonal. Go up 1, 2, 3, 4, 5, 6. You can see that there is a very tight lesion at the diagonal ostium. And yeah, so at 6, it is not given way. 7, 8, 9, 10, 12, still not giving way. Very tight lesion. 13, 14. Yeah, now at 14, it has given way, you see? And we can bring it to 8 now. 8, and keep it like this for about 15 seconds, 30 seconds. And then we will see how it looks. So this was a very because the whole plaque complex is fibrocalcific. So you saw that it went at very high pressures. Deflate, please. So do you want to take a cutting balloon here?
Yes, so it will also help in circumflex, treating the circumflex. So we'll prepare
Yeah, so
this
we
bed.
can take a 2.25 cutting balloon, but first we will dilate the
LED.
LAD with the same balloon. And I'm taking this. Okay. Yeah. Yeah. So here we are with the check, please. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 16. So we have used the same balloon to dilate the LAD. And now I will deflate it. Deflate, please. And see how it looks. Yeah, it is moving well. So to avoid situation of branch occlusion, sometimes we also resort to a strategy of no stents. Can you check? Yeah, looks better, but we have to dilate more. The diagonal also needs to be worked on a little bit. So we can use a cutting balloon now, 2.25, 2.25, or a 2 millimeter. You have a
2.25.
2.25, yeah. So I'm taking a 2.25 cutting balloon for the diagonal ostium, which did take some time to respond to the balloon. So we'll see how it can help and then see how it goes. Okay. So you see
Because
how
it's almost
badly the
90 degrees.
stenosis is. Can you just give me a talker, please? Yeah. So the wire actually kinked at that place. Check, please. So I'm just trying to put the wire as distally as possible. And again, can you connect? So you see how much calcium is there. So it is not able to enter. Although we have cracked it with a 2 millimeter balloon, but it's not entering. Okay?
Guideliner.
No, not guideliner. First, we'll do the dilatation of this
LED.
LED.
So it will modify the other
Yeah,
part.
sometimes we modify the basic plaque in the left LAD, and then we will see how it goes. So keep it on the side.
3 cutting.
3 cutting.
3 cutting.
Give me a 3 millimeter into
15.
15 or 10, whatever you have. 3, 10 or 15. Okay, give me. So I'm taking again a cutting balloon. So this balloon went in very easily. Check, please. Yeah, now I think we are at the right position. So we can cut it 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 16. Okay, so this expansion is looking quite nice and good. This is okay. Deflate. Deflate, please. Check, please. This is looking all right. Okay, go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 16. So we are going up to 16 atmospheres. How much is the size with this Wolverine now? Deflate, please.
Is almost 3.3.
Show me the distal wire, please. Yeah. Okay.
Balloon.
So I'm pulling the balloon back. Okay. So this is a 3 into 15 Wolverine, right?
Yes. 2.25.
And we got a good expansion. So we can check now. That looks very nice. No dissections. Yeah. And the diagonal is also patent. So I'll try and see if we can enter into this diagonal again. Otherwise, I'll use the.
Sometimes you do this.
No, that is not going to help here because it has got the blades. So the blades actually make the balloon a little stiff. That is the reason it doesn't cross. But we have modified the plaque a little bit in the LED, so it might help. So we will see. So we can take questions if they are coming up. Somebody can get the questions, read the questions. Okay, no, still it is not behaving so well. No. So I'm not able to cross this diagonal ostium, which is a very fibrotic lesion. And no, not at all. So I will do a balloon dilatation again using the same balloon which we used earlier, which was a 2 millimeter, 2.25. 2. So keep it on the side. Ask Tender if he has the questions on the Slido. Yeah. I don't know what happened to this. So we can take another balloon. Give me a new balloon, 2.25. 2.25 into 12. So you see how much interplay happens that the plaque modification needs to be done in such kind of fibrocalcific disease. And give me a balloon, please.
2.25.
2.25 or a 2.0, whatever.
2.0, 210.
So,
The scoring.
so here we are now just a little bit struggling to take the diagonal dilatation again,
You want
because
scoring?
we still want to do it with a cutting balloon
Scoring will help.
eventually. Give me a, yeah, scoring is also fine.
210 scoring.
Yeah, give me this. Yeah, 2.2510. So we are taking a 2.2510 NC Apollo balloon, and we will see how this moves. Okay. Look at that. This is something very, very interesting. And that now this balloon is not
Scoring will.
moving at all. Okay. So this 2.25 into 10 is not entering, although we have dilated this diagonal already. But because of some calcific spur or some fibrotic band, this is absolutely not responding. So we will take this out. And now I'm going to take a 2 into 10 pouring balloon, because it has a thin tip which actually helps enter into these locations, and then followed by a 2.2510 scoring balloon. Leave it like this. Keep it here.
LED wire has started.
Any questions? Ask Tejinder if he has on the Slido.
Yeah. There is a question: what are the potential complication or risk associated with using a cutting balloon in LED?
Yeah, so the potential complications can be that, somebody asked this question, that potential complications. So in this situation, I can tell you that it can lead to sometimes a perforation, or sometimes, a large dissection. But we have seen that with this Wolverine, when you are doing these fibrocalcific lesions, even at high pressures, it is reasonably safe to do that. And that's what you witnessed also. Yeah, now we are again back into this, and you saw that this scoring balloon entered quite easily. So we are going to dilate this with a scoring balloon. Go up. This is a score flex. Go up from Orbis niche. 6, 8, 10, 12, 14. 14, deflate. Okay, I'll push it a little bit further down. Go up. 2, 4, 6, 8, 10, 12, 14. You see, you can see the two wires on either side of this balloon inflation, and that's the the hallmark of this scoring balloon, score flex. Okay, go up. 1, 2, 3, 4, deflate. So it appears that we don't have to do any further dilatation here. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay, deflate. So there is no residual now with the scoring balloon, and now I can cross it very easily. So which means we are fine. Okay. Check, please. Yeah. So there is no major dissection in this diagonal, and it has been dilated well, and the LED also looks reasonable to me. So now there are two options. One, that we put a stent here. Two, that we don't put a stent, just to a drug-eluting balloon. Okay.
You will get this lumen if
So,
it is good.
what is this?
I was to see.
So we will check the lumen now of the LED and see if we have gained a good lumen without major issues. So we might just finish with a drug-eluting balloon also, because that will do two things. There is no jailing of the side branch, and the second is then of course the chance of needing a second stent will also be minimized. Okay. So pull back. So show the IVUS images, please. On the, so here you see
We can go.
that the lumen is quite good. I'm pulling a little bit back. Yeah. Yeah, lumen is reasonably okay. Stop.
Cutting.
Sometimes this, catheter starts sticking to the wire. That's what was happening. So I pulled it out slowly so that we don't lose the wire position. And we will check if we are okay. Yeah, we are fine. So now we can dilate a little bit more with this in this LED.
Yes.
And then see how it is. Okay. So how much is the luminal gain? How much is the lumen now?
6.4.
6.4 square millimeters is the surface area. And the minimum is 6.4. Okay, that's very good. So if we have a minimum of 6.4, I am quite happy with this. Yeah.
5.8.
5.8 and 6.4. So there is quite a nice, happy situation for us. Okay. Okay. Check, please. Okay. Yeah. Go up. 1, 2, 3, 4. Pressures. 5, 6, 7, 8, 9, 10, 12, 14,
Fluid.
16. Deflate. Okay. 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 So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 16. So we have gone up to 16 atmospheres and now we will bring it back. Deflate, please, and see how it looks. Okay. Let it deflate. Okay. So I've done second round of inflation and we'll see how it looks. Check, please. BP process lower. Next second. So, sir, give some saline, please. Yes, some vasovagal, it seems. Sometimes they have. Okay, check. Yeah. The heart rate is okay, 50 now. Okay. Let's check a little bit. Check.
Yes.
Okay, fine.
Flow
Okay.
is not.
There is some slow flow.
Termin. 1 ml.
So there is some slow flow. Give some atropine also. Atropine 0.6.
Fluorosave.
So we'll give some atropine because he has got some vasovagal. And keep giving some saline, please. Yeah. The pressures are okay. Continue checking the pressures. But the lumen looks quite good actually. How much? Atropine? 0.6. Okay, fine. Heart rate is 48, 46. So it is typically a vasovagal thing because these patients are sometimes fasting. It's 4 o'clock in the evening, 4:30. So that may be the reason. Okay. So we'll see. Give some saline, please. So let's give some saline first.
There is one more question.
Any more questions?
Yes, sir. Are there any calcification or plaque characteristic that may impact the choice of cutting balloon?
Yes, if it is a, so the question is if there are any different plaques where we choose different kind of cutting balloons. If the calcification is like ring-like and is more than 180 degrees or is deeper in nature, in these cases we definitely take a Wolverine. But in sometimes if we are not able to cross, as you saw, and in a ostial location, we first dilate it with the Scoreflex, which is another type of scoring balloon. So this is what we do. Now you see that the vasovagal is corrected. His heart rate is 80 now. and his pressures are also okay. We gave some saline. I'm also pushing some saline so that he feels better. Okay. So this is very important that we have to keep the procedure as safe as possible and also keep checking out the hemodynamics, the heart rate and everything. So we gave about 100 ml of saline, both from IV and from the sheath. You can inject from the sheath also sometimes. And this wire is LED and this is the diagonal. Okay. So let's take a shot and see how it looks. Okay. Check please. That looks very nice actually. To me, it looks like a stent-like result.
Yeah.
And I'm very happy to put a drug-eluting balloon here. So we can take a 3.5 into
20 or
15 or 20, 20, 3.5, 20.
Will be doing kissing or single?
I mean, you know, I think for the diagonal, we can do a drug-eluting balloon also. So in that case, we should do the diagonal first and then do it this one. Okay. So give me a 2.25 into 10 DEB for the diagonal. 2.25 into 10. Two point two five into 10. 2.25, 15. No, you can give this one magic touch. You have magic touch. 2.25 into 10 or 15. So we are looking at, we have two options and we are looking at these options. And but I'm very, very happy to do it with a drug-eluting balloon. Okay.
Yes.
Because the vessel is very well opened up. The flow is excellent. And we see that there is no dissection. Yeah. So in this situation, no, give me the 15, 2.25, 15, essential, not essential,
Solution.
the solution. So solution is basically a sirolimus eluting stent, and this balloon, essential, solution is a sirolimus eluting balloon, and it has a very different kind of technology, which is encapsulation of these. Yeah, give me 2.2510. So we found a 2.2510, which is our preferred size here. So we'll take this magic touch from Concept Medical, and we have been using this balloon for a while now with good results. So this is also sirolimus eluting balloon, magic touch.
It has some nanotechnology.
Yeah, this is a nanotechnology for again phospholipid core actually holds this drug together and then releases it within the folds of, don't prepare it, within the folds of the balloon. So you don't have to prepare the balloon unless until it reaches the lesion site, because sometimes these folds open up. So let the balloon go slowly inside. Okay. Yeah, so this is the, yeah, so now you can see how easily the balloon went inside without any issues. And can we check now a little bit? Check. Yeah, it's fine. Go up 1, 2, 3, 4, 5, 6, 7, 8. Okay, 9, 10, 12. So I'm doing a balloon inflation with the drug-eluting balloon, and this is the magic touch 2.25 into 10, which is being done to this diagonal. And we will keep it this way for about more than a minute. And generally we go for 2 minutes if the patient is able to tolerate this. In the meantime, please make ready 3.5 into 20 magic touch. Well, we have to make it FOC. 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 Okay, so here we are fine, and 54 seconds, and everything is okay. The patient is having some pain, but we will keep it like that. Hemodynamics is okay, and we are good. Okay, so 2
320.
minutes. 3 into, no, 3.5, 15 is okay. Yeah. 15. Okay. So it is 1 minutes 23 seconds, and we will stop at 1:30 because he's having some chest pain. So we'll stop at 1:30. Okay. Deflate, please. So it's 1:34, 1 minutes 34 seconds. And I'm taking this out. Okay. Right. Okay. Yeah. So we are taking because this vessel was slightly bigger than 3, up to 3.25, and at approximately it was 3.5. So we are taking a 3.5, and we don't have to go to high pressures because we have already done high pressure inflations with a 3 into 15 cutting balloon, and the size of cutting balloon becomes how much? 3 point,
3.4.
almost 3.4 at the pressure of 18 atmospheres. So 3.5 seems to be a good size for this vessel. Okay. Please connect now. Please check, please. Okay. Check, please. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So we are at 10 atmospheres, and with this 3.5 into 15, again this same balloon, Magic Touch, which is a sirolimus eluting balloon, and again made by Concept Medical in India. And the wire in the diagonal stays there. Patient's blood pressure is okay, he's fine, and we will see how it goes. Okay. So keep giving some saline, and now his heart rate is okay. So that episode of vasovagal is really settled. Okay, fine. Great. Okay, fine. So this is 1 minute now, and we will try to continue it for another 20 seconds, 30 seconds. And although recommendation is that it should be between 30 seconds to 1 minute, but we generally try to do it for 90 seconds to 2 minutes. Okay. His blood pressure is 80 systolic now, but we will continue. We can continue for another 10 seconds. So this is 1:30 now. 90 seconds is over. Deflate, please. So he's having pain. We'll deflate it. Okay. Okay. Please deflate now. Okay. Bus. Wire is sticking. I don't know why. Sometimes this BMW has a coating which becomes a little sticky. And we will see how it looks. Okay. So we can check now. Just the blood pressure be better. That looks nice. Okay. I'm wedging here. So let the blood pressure be better. So his BP is okay now, touching 100, and gradually recovering. Yes. Okay. Let's check little bit. Check a little bit. Fine. Okay. So we can do a shot here. That's fine. So both the vessels are flowing nicely. The LAD in the diagonal, there is no major dissection. So let us come to the RO caudal projection. Ariocaudal. Okay. Dikhao. Show us.
Dye staining is
There's some dye staining there.
oh,
Okay,
that
fine.
other branch.
So, so there is a dissection which I can see in the distal part of the vessel, and we will see in the other views. Heliocranial, please. Heliocranial. Hmm. The lumen looks quite good actually,
Yes.
but I can see that there is probably a dissection.
Which one? This
This
distal
distal
one is.
Can you come to the back shot? Previous shot, please. Previous.
The proximal is the dye holding in the
Yeah,
ramus.
yeah. The previous shot, please. Previous. Yeah. I mean, this looks quite good actually, if you look at it. The vessel is very well opened up. And overall, I will say that it's fine. Yeah.
We'll remain watchful. We'll do the
Yeah,
left circumflex.
and then we can see. So we are going to do the circumflex now, and we will see. In case there is any issue, we can still watch for another 20 minutes or so while we are doing the second artery. Yeah, and the flow is quite nice. Okay. The diagonal flow, the LED flow, everything is okay. Go to the next shot, please. Next. Yeah, in this, there is a suspicion of that dissection. Anyway, we will do the IVUS now. Let's do the IVUS. We will do the IVUS and see how it is. Epicranial. Ask him if he has still pain. Ask him about the chest. How is he feeling now? Feeling okay? क्या कह रहे हैं?
पानी दे दो थोड़ा सा.
दिखा दो. थोड़ा पानी दे दे. Give some water. There is some staining of the dye which I am.
No, sir, that is
seeing
in
now.
the RI, that ramus intermedius branch.
No. Okay. Okay. So we have the IVUS pictures now. This looks okay. The lumen looks very good actually. Even in this segment, I don't see any major issues. So look at the IVUS pictures. Yeah, there is a dissection on this side. I can see that. Where is this now? Let us see. Check, please. It is in the proximal segment. But the lumen is not compromised at any stage.
Yes.
The lumen looks okay. And proximally also the lumen is okay. So I think we can just hold on and see. So what I will do is, typically I will leave this wire here for a while and take the diagonal wire and we'll start treating the circumflex. Okay. Okay. So come to the ariocaudal projection, keep the wire here, put a sheet here. Yeah. Okay. So now hopefully we are done with this LED. As the lumen looks good, everything is fine. Okay. So I'm trying to wire this distal diffuse disease of the circumflex. Check a little bit. No. Okay, so we have crossed this in a branch. Check, please. We have entered in a branch. I want to go distally in this side.
दो का balloon.
Mm. So it is entering in a small branch, as you can see. No. We might have to do some changes in the check.
Yes.
Yeah, so we have crossed, and it's a
Looks
little
quite
bit
tight.
in a smaller branch now, but we can go to a bigger branch. Check, please. Yeah. Okay. Okay, so we have a 2 millimeter balloon. So we take that to score flex. Yeah, this is a score flex. Give me the score flex 2 millimeters for pre-dilatation. And then we can see how it moves inside. Typically, a score flex is a balloon which can cross easily, but of course, the cutting effect sometimes may not be adequate. So we will see.
Dissections are more.
And sometimes we have more dissections also. And but anyway, so I think this is a good balloon for pre-dilatation. Check. Check, please. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Deflate. So it is slipping a little bit back. So I will go a little bit deeper inside. Okay. Check, please. Yeah. Go up. 2, 4, 6, 8, 10, 12. So we are doing the inflation of the first lesion. Deflate, please. Check now. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Deflate.
Lady wire, we can push.
Okay, so we have done the dilatation here, and show me. I'm going to the distal lesion.
LED wires.
LED wire will be okay, don't worry. Okay. So this is a very tight lesion down, but we will persist a little bit and it will go. Check now. Because as I said, these balloons are quite okay for crossing. Go up. So we have crossed it. Go up 2, 4, 6, 8, 9, 10. Okay, deflate. Okay. Check, please. Yeah. So we have go up.
Yes.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Deflate. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Deflate. What is that?
The ramus
Can you
branch.
deflate.
I don't
No,
know
but
how
there is the ramus branch is this big one.
ramus has
Deflate.
one more branch which is occluded.
Deflate.
It's not LED. sir. ऊपर
Yeah.
तो हम गए नहीं.
Okay, check. So this vessel is now very well opened up, as you can see. And looks quite good.
We can leave it.
Yeah.
Just proximal.
Okay. So we can
Yeah.
finish it off with a maybe a DB.
Yes.
Yeah, 2 point or 2 stents. We can use 2 stents distally and then proximally. Give me a balloon, please. 2.25. 2.25 we have.
We have
2.25,
Wolverine.
15.
We have Wolverine also.
Yeah, Wolverine 2.25, 15. Show me the first shot, please. First shot. Okay. Next. 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 We have iliocaudal projection.
Iliocaudal. Next.
So check please. So we are going distally first. Go up. 1, 2, 3, 4, 5, 6. Okay, that's fine. 6 is good. Deflate. 6. 6. Okay. Deflate. 6. 6. 8. Deflate. Check please. Check. Yeah. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. So at 14, it becomes almost like a 2.5. Deflate, please. Deflate. Check. 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 Go up. 2, 4, 6, 8, 10, 12, 14, 16. Okay. Deflate. Okay. So bus 5 minutes or. So now we will look at because there is some wedging. There is some disease in the left main. Okay. Okay, fine. Now check. Yeah. I mean, this vessel looks very good to me. I mean, I am tempted to do a DEB to this vessel also distally. Or we can put maybe, 1 or 2 stents. Okay. So we can do an IVUS now?
Yes.
Yeah. So let's do an IVUS.
Maybe LED dissection. Big vessel. Quite big vessel. 2.5.
Okay.
Display.
So this is the distal vessel. Looks good. And I mean, here also the lumen is quite okay.
Yes.
We got a good lumen here. Got a good lumen here. Yeah. And all this is quite okay. Here again, there's some plaque, but the lumen is still fine. And we can put a stent proximally.
Stent.
Half stent. Okay. Okay. So give me a balloon. How much is the distal vessel size?
2.5.
2.5 or 2?
2.5, sir.
Check please. Check. Talker, please. Okay. We can disengage a little bit. Check. बस हो गया. Okay. Okay. Give me a DEB for distal vessel size is 2.25. So we can take a 2.25 into 25.
For
2.25, 25.
distal, sir.
So distal. Yeah. Can we check a LEO caudal
caudal.
shot? LEO caudal, please. Okay.
It's LED only.
Yeah.
Yeah, LED.
Yeah, there is a distal dissection in the LED,
Which is going towards.
which is
diagonal.
leading to a lot of staining here. So we might have to put a stent because it is extending into the proximal segment. So let us fix this and then we can decide. Okay.
Yes.
Yeah. And we can put a stent here also because the lumen is not so good in the proximal circumflex. Allow. Yes.
Magic. Magic.
Show me.
2.524 will have.
2.25.
Magic.
Uh-huh.
Magic. 2.2520.
Yeah.
25. Yes. There. 24. 2.5.
So we can see now that the dissection in the proximal LAD is something which will need some attention. So we will fix that. And that's why I kept the wire there for a while. There hai.
Yes. Yes. Pani.
Okay, come to RO caudal.
RO caudal.
Okay. So here I am. Okay. Check please.
Yes.
Go up. 1, 2, 3, 4, 5, 6. So we are doing a DB dilatation in the distal vessel, which is like 2.25 only. And proximally, we will put a stent. Okay. So to give me a stent 2.5 abluminous or something. What do you have? 2.5 stent. 24 and also give me a 28. Keep a 28 here. Okay. So his blood pressure is okay. He has chest discomfort though because we are handling somewhere or the other. So this inflation is on 35 seconds and we will keep it for another how much? Another 10 seconds, 20, 30 seconds?
Yes.
30 seconds. Okay. Okay. This is 1 minute now. And go to LEO position, please. LEO. LEO. Go to LEO. LEO. Deflate. Deflate, please. So it is 1 minute, 20 seconds. Deflate. I want to use this balloon to measure the size of the stent here. Okay. Check. Okay. This is 25. Yeah. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 8, 9, 10. Deflate. So what was the length? It was 25. I think 28 will be fine. Give me a 28. Okay.
2.528. Is our 28 promise.
28 ka promise.
Now we have to do it from the ostium. LED planning.
More or less. So we are taking a 2.528 stent for the proximal LCX so that this part is done. And then we will look at the LED again. Okay. This diagonal, although is flowing nicely.
You want OCT also?
We can check OCT. Yeah.
OCT.
OCT, please. So for little bit further down. Okay.
Yes.
Okay.
In this view, we can check.
RO caudal, please. RO caudal. Okay. Center. You can go a little bit further down. Okay, check. I think we are okay.
Yes.
Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay. Distally, we cannot go any further.
Yes.
So for 30 seconds, deflate.
Rika
Okay.
ox. 2.5 ox.
Okay. 2.5 balloon for post dilatation. Okay. Fine. So we are now done with the circumflex. Hopefully, we'll do some post dilatation of the stent proximally, and then we will see how it goes. Okay. Yeah, that looks nice. So we are okay. The distal part is ballooned with a DEB, and proximally we have put a. So this is kind of a hybrid, which we do sometimes. So if the proximal lesion needs stenting, with stenting.
Agreement start.
Okay. And how much heparin have we given? 10,000. Okay.
That's almost.
We can do a OCT, ACT also
Yeah,
at this
it's almost
stage.
400.
Okay, 400. So which is fine. Okay. Okay. Can you show the stent boost? Okay, go up. 2, 4, 6, 8, 10, 12, 14, 16, 18, 20. Deflate. So this is quite nice. And 2, 4, 6, 8, 10, 12, 14. Deflate. Deflate. And we are going to do some more dilatations now in the distal segment. Okay. So go up 2, 4, 6, 8, 10, 12. We will not go very too distal. 12, 14. Deflate. And okay, go up 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Deflate. Okay. So I think we are, kind of done with this post dilatation of the stent. And okay, check please. So we can take a final check shot of this artery. Yeah. That looks nice to me. Okay. Some nitro, please. Some nitro.
But there is some haziness in all the osteas. Right, haziness.
So there is a proximal dissection which we need to really seal off. Okay. Because we cannot leave this artery with this kind of a situation, hopefully, but we will check. I'm going to check on OCT. Epicranial, please. Epicranial. Show me. Center. Okay. 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 OCT, please. So I will do a OCT now to check for the extent and the depth of this dissection, which is better seen on OCT. So I'm going to do that now. And then we will take the final decision regarding the
Connection.
LAD, whether we need to do a bailout stenting for the LAD or not. Okay. So they are preparing the OCT. पकड़ लो. Okay. बस हो गया. उसमें खोल दिया. So his blood pressure and heart rate, everything seems to be stable. And we are ready with the OCT now. Correct? So the run with the OCT is going to happen now.
20 ml.
Once it is ready. 20 ml lower lock syringe.
20 ml liver lock.
Okay, ready? Okay. Ready? Okay.
ये बंद कर दो लेजर.
नहीं आवाज आ रही है ना बंद कर दो उसको. Just stop that. Okay. Okay, fine. A little bit more. Deeper. Okay, fine. Okay.
Ready.
No, just check if we are engaged properly. Huh, yeah.
Ready.
Okay, ready? अभी नहीं. Yeah. Okay.
This
Yeah.
dissection is going up to diagonal also. It's extending into diagonal.
Extending into the diagonal.
Better to-
Remus. Show me the whole thing. Yeah. Okay. Show us. Yeah. So from the left main, go down. No, go down.
Distally.
To the distal. Go 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 distal. Yeah. Go distal. Yeah. Okay. So the ostium of the LED is still fine, but ostium is okay. And go down. Here it is. Yeah. So there is a hematoma which is happening below the artery. Go down. Here the lumen is little less. So we need to, cover it up. We take a stent, 3 millimeter stent, please, or a 3.5. Give me a 3.5.
3.5.
Go distal. Huh? Go distal.
20.
20. Maybe you can take a 28 or something.
3.5, 28, 20, 24, 28 ले.
24. Onyx दे दो. 26. 3.5, 26 onyx. So we need to take a stent
थोड़ा सा पानी.
which has less issues about the side branch occlusions. Okay.
So you
So
want to do the
let's come to
diagonal-
the iliocaudal position or epicaudal. Epicaudal, please.
diagonal
epicaudal.
wire you want to do. Diagonal wire.
Not required. Okay. Center. Okay. Check a little bit. So we will do a, okay, iliocaudal, iliocaudal. Okay. Give me the stent, please. So this is something, you know, which we see at times.
26.5 length.
Yeah, give it.
It will be cut to
What
cut.
is that? What are you saying? Length is how much?
The extra
28. So we can take a 28 then. Give me a 28.
compress the hematoma.
A 28 of anything. So the circumflex is flowing well. There is no problem. The distal DB segment is okay. Proximal segment is okay. So we'll need to fix this LAD as we see here, this dissection and hematoma, which it's better to fix it now. Okay. Or abluminous 3.5, 28 abluminous.
3.5, 28 abluminous stent.
Abluminous stent 3.5, 28. Okay. So we will take us, I think 28 should be fine. Yeah. Because if it on the OCT it is showing a length of 26.7, it will be better to take a 28. Give me. Give me. So this is the SR summit stent 3.5, 28. Yeah. And with this stent also it's an open cell design. So generally the side branches are less affected, but we will see. I cannot promise anything, but we can check. Okay, connected. Center, please. Center. Okay, check. I can't see anything. Go more Elio caudal, please, and remove the screen. Go push the screen back a little bit. Push the screen back. Okay. Go more Elio. Go more Elio and caudal. Yeah, that's better. Now it is better. Okay. So I can pull a little bit back. Pull a little bit back because. Okay. Okay. Yeah,
Yes.
I think this is
Yes.
fine.
Yes. Distally we are good.
Yeah, we are okay. Okay. Okay, come to the epicaudal position or ariocaudal. Ariocaudal, please. Center. Okay, check please. No, this
we
is
are in left
this
main.
view. It is too much inside the.
Yes, left main.
Okay, so can we see in the other view? Elio epicranial, epicranial. Check. No, I can't. Can you go to the other some other view? Eleocranial. Let us see, because we have to really clearly see where we are landing proximally. And no, in this view also we don't see that much. Okay, so come to the eleocaudal again, or epicaudal, epicaudal, epi. Yeah. Center. Okay. Okay. Check please. Yeah, we can go a little bit deeper inside.
Yes.
Yeah.
this is fine.
Okay. 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 Go into the eleocaudal again. Deep eleocaudal. I think that is the only view it shows where we have to land. Okay. Center. Center, please. Center it. No. Center the. Go eleocaudal as much as possible. Caudal, please. Caudal. check. I think we should be okay.
Yes.
Okay, okay. Okay, go up here. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. Okay. Deflate. Epicranial. Epicranial.
Ectopics.
The wire has got pushed a little bit deeper inside. Okay. Ariocaudal. Ariocaudal now. Ariocaudal. It is demagnified. Ariocaudal, please. Center. That's right. Okay. Check, please. This looks nice.
Branches
Yeah.
are required.
So now we see that the flow in this, maybe that hematoma was compressing somewhere. Yeah. Yeah. And the flow is quite good. The diagonal is also flowing still. So we are fine. Should we do a OCT or yeah, we can do a OCT again. Yeah.
There is one more question.
I don't hear that. Tell me again.
Question.
There is one more question. Yes.
Yes.
That what type of stent is the most suitable for this specific situation?
Yeah. So in this specific situation, the question is which is the best suited stent. So we have to take a stent which has good access to side branch or has an open cell design. And in your experience and in your lab, you have to know which stents are those. And then depending upon that, you should make a choice. So in our selection, we find that this SR submit again is a very open cell design, and typically the branches actually behave quite well. And so we chose this stent. Okay. No, I think there is some problem with this wire.
Other wire.
No, don't pull, don't pull, don't pull. I will take this wire out. It's not required anymore. Yeah, take this out. So as I was telling you, this wire is a little sticky wire, and this OCT catheter is sticking a little bit. So we have to be a little careful. And if in case we have some difficulty, yeah. So again, we see that it is sticking in the stent. So I will take the IVUS catheter.
Yes.
Because it is sticky, and I don't want to push it too much. And we will take the IVUS. We already have the IVUS. अभी कर रहे हैं. थोड़ा देर शांति से रहिए. बोलो उनको. So you can see that the staining has also reduced quite a lot. And
और जी हो गया है बस.
I think
10
this
मिनट में
wire is
आपको बाहर
really
कर रहे हैं, बहुत अच्छे रिजल्ट
giving
आ
us
रहे
a
हैं.
lot of
ठीक
trouble.
है,
You
थोड़ा
see,
शांत रहिए.
when I'm pushing this wire has
बस अभी
created a problem. So it is the problem of this wire. Okay, that things are sticking on it. Can we do a check shot? So let's do a check. No, not with this. Check. This is something which we have seen with these BMW coatings sometimes. I think this looks quite nice. The staining is completely finished and looks quite good. Yeah. Epicranial, please. So I will do a 3.5 dilatation again, little bit, because we have gone only up to 12 atmospheres. Give me a 3.5 balloon. Center, please. Yeah. Take a shot. Yeah, this looks quite nice. And you can see that the diagonal is also flowing very nicely, and the lesion is responding very well now. So everything looks okay.
NTG I'm doing.
His flow to the LED is also very nice. Okay, let's go and check. Go up. Deflate. So here it is, a 3.5 balloon for the post dilatation. Can you switch it off? Again, the same problem is happening, but we will see if we are able to handle this. No. No, it is not. Give me another NY 3.5. This balloon is not crossing, so I'll take another one. 3.5 NY.
3.5 NY.
Just hold on. Ah. Okay. This is 3.512.
Yes.
Okay. So we'll see if this one goes through, because this is the problem of this wire. And I don't want to really change the wire at this stage, because the stent is up to the ostium. We have to knuckle the wire and then go accordingly. It's the same place, but this time probably it is crossed. So somehow, but the wire gets pushed every time I push this. So anything inside, it gets pushed. Okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Deflate. Deflate. Okay. So I'm pulling and pushing the whole thing at once. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. 14. Okay. Deflate. Okay. So now let's come to the. Okay. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14. Deflate. RO portal. Center. So we'll do a stent boost here. Stent boost. Okay. Now we are okay. Go up. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12, 14, 16. Deflate. So I think we are almost done over here, and we'll take this out. Okay,
Yes.
fine. So we'll take a final shot. Hopefully everything is okay. Yeah, this is looking nice. All the vessels are flowing well. The distal circ is good. With the DB, the proximal circ is good. The LAD and the diagonal, everything is flowing. So I think with this, the whole procedure is now over, and we can pull this guiding back, and that's all. Okay. So thank you very much, and I hope this was of value to everybody, and we'll see you again next week. All the best. Bye. Okay.